Today we will speak about very important topic, which is very important for every physician acting as obstetrician. This topic is induction of labor. What's meant by induction of labor? Induction of labor is the artificial initiation of labor mechanism prior to its spontaneous onset. Very important to prior to its spontaneous onset. So it must be differentiated from augmentation of labor, which is mean increase the duration of contraction or the frequency of contraction in cases where the onset of labor is already started. So this is the difference between augmentation and this is the difference between the induction of labor. What is the goal of induction of labor? The goal of induction of labor is to eliminate the potential risks to the fetus with prolonged intrauterine existence, minimizing the likelihood of operative delivery for cesarean section, and also for a benefit, great benefit if there is a general maternal disorder or disease. The main indication for induction of labor is the hypertensive disorders of pregnancy, diabetes mellitus, renal diseases, chronic pulmonary diseases, premature rupture of membrane, Rh isoimmunization, post-date pregnancy, and there is contraindication of induction of labor in the major degree of placenta previa, previous classical uterine incision, cephalopelvic disproportion, active genital herpes infection. There is a relative contraindication is the malpresentations. Also, it is a contraindication is the malpresentation, previous hysterotomy, uteroplacental factors in the form of unexplained vaginal bleeding, vasa previa, cord presentation, cord prolapse, cervical or pelvic tumors. Induction of labor can be done with a special caution, especially in cases of previous lower segment cesarean section, multiple pregnancy, polyhydramnios, especially severe form, maternal disorders, especially heart disease, severe hypertensive disorders with pregnancy. As regards the induction of labor, there is very important items is the time, place, and the preparation of the induction of labor. As regards the time of induction, preferably early in the morning to have enough time all over the day to interfere if there is any complication maternal or fetal and have an adequate time for accurate judgment for success of induction of labor or failure. Number 2 is the place of induction where the feasibility for intervention and fetal monitoring is available, especially a good pediatrician must be present. Preparation of the patient, enema may be given to the patient prior to induction. Prerequisites before induction of labor, maternal prerequisites must be fulfilled in the form to confirm the indication for induction, exclude the contraindication, assess Bishop score, assess pelvic adequacy. Fetal prerequisite before induction of labor is ensure fetal gestational age, ensure fetal weight presentation, confirm fetal well-being, and lung maturity. After all these items must be fulfilled, the patient must be write and informed written signed consent. We must evaluate the pelvic examination before induction of labor in the form of Bishop score. Bishop score has 5 items, which is dilatation of the cervix, length of the cervical canal, consistency of the cervix, position of the presenting part, and the station of the head. Position of the cervix and the station of the presenting part. Each item must be evaluated and has a certain score 0, 1, 2, 3. After evaluation of 5 these items, we can sum the scoring of the Bishop score. Favorable score equal or more than 6. Best score is 8. But the modified Bishop score include adding 1 point for the previous calculated Bishop score. We can add 1 point for preeclamptic patient each previous vaginal delivery. For example, if the patient has a past history of 2 previous vaginal delivery and they had a 6 favorable 6 Bishop score, so we adding 2 points, so the net result of the score is 8. On the other hand, we can subtract 1 point for the Bishop score if the patient is post-late pregnancy, if there is nullipara, if there is preterm premature rupture of membrane. A very important item for the success of induction of labor is the ripening of the cervix. What is meant by ripening of the cervix? Ripening of the cervix is a normal physiological process that precedes uterine contractions and include highly complex biochemical process. This biochemical process will perform remodeling of the cervix, which usually occurs spontaneously towards the full term. It includes number 1, dissociation of the collagen bundles of the cervix, increase in water content of the cervix, which facilitate easy dilatation in response to uterine contraction, invaded by massive neutrophils and macrophages with release of different types of interleukins. The termination of normal pregnancy usually occurs in 3 stages. According to this stage, different types of modalities can be performed or preferred for accurate success of induction of labor. If the patient in the pre-labor stage, it needs certain types of inductive methods. If in cervical ripening occur, the patient needs another method. If there is a patient in active labor or early in labor, another types of inducing agents can be used. Endogenous prostaglandins, they play very important role in these 3 processes. This is the 3 stages of the labor: pre-labor stage, latent labor, active labor, and delivery. According to the stage in which the patient admitted, there is another type of or specific type of inducing agents can be used. If the patient in the pre-labor and early latent phase, prostaglandin is the most specific and the more suitable inducing agents. In the patient later latent phase and in labor, amniotomy is preferred, but especially if the cervix is opened and the bag sac for water is well formed. If the patient in active labor, the oxytocin is indicated to perform strong and sustained uterine contraction. As regards the different types or methods of inducing labor pain in labor, there is different classifications of the inducing agents. Membrane sweeping is most commonly used. Prostaglandins can be used. Amniotomy and oxytocin, these are the most common inducing agents can be used. Different types, stripping of the membrane, amniotomy can be classified into pharmacological preparation, prostaglandin, oxytocin, relaxin. Rare methods not used nowadays in a large scale: mechanical dilators, balloon catheter, laminaria tent, osmotic dilators. Different classifications in different textbooks can classify the inducing agents into mechanical methods and surgical methods and pharmacological methods. Mechanical methods, hygroscopic dilators, placement of balloon dilators after 42 weeks gestation, or surgical methods in the form of stripping the membrane, amniotomy. Number 3 pharmacological methods is the prostaglandin E2, prostaglandin E1, mifepristone, and oxytocin treatment. Now we will discuss each method, its advantage and disadvantage. Number 1 is the membrane sweeping. It's possible only if the cervix has ripened to allow the passage of one finger through the cervical canal all around the head. Insertion of gloved finger through the cervix and its rotation against the wall of the uterus. It strips off the chorionic membrane from the underlying decidua, which help in release of the huge amount of the prostaglandin. Placenta previa should be excluded before doing this maneuver. Also, accidental amniotomy is a side effect which may occur as a major disadvantage. If it accidentally occurs, the patient must be kept in the hospital inpatient, not transferred to home. In general, this maneuver can be done and the patient can go out to home, and it comes with strong uterine contraction after 2 to 3 days later on. But if amniotomy is accidentally done, the patient must be admitted to hospital. This disadvantage of the sweeping of the membrane is the ascending infection, bleeding from the placenta previa, which is usually undiagnosed priorly, accidentally rupture of the membrane. As regards the advantage, as we said, it helps in the release of a large amount of prostaglandins, which make spontaneous onset of labor more likely, reduce the need for formation of formal induction of labor. It's usually done at 39 weeks gestation. The second maneuver is the amniotomy. Amniotomy is the artificial rupture of the membrane using amniotic. This is the amniotic. It is long and has a certain curved sharp point. It must be admitted through the two fingers to be safely admitted through the cervical canal till we reach the bag of water, and certain scratching in the bag of water release the amniotic fluid. It needs a patulous internal os and well-formed bag of water. The patient is asked to empty the bladder before this maneuver to avoid injury of the urinary bladder. Ideally, is done in the active phase of spontaneous labor, which is allow the dilatation of the cervix and formation of the bag of water. Artificial rupture of membrane is done through stretching of the cervix and separation of the membrane and release of the prostaglandin. Depends on the state of the cervix. If it is favorable and the station of the head it is engaged, the onset will be rapid for delivery. It has many advantages: high success rate, a chance to see the amniotic fluid nature if there is meconium or there is blood in the amniotic fluid, which helped me to change my decision from the induction to immediate cesarean section if there is thick meconium or large amount of blood. Also its advantage is to shorten the inducing delivery interval. The inducing delivery interval, which is the time calculated from the onset of induction till the delivery of the fetus. But in general, any maneuver has disadvantage. It can't be applied if the cervix is unfavorable. So what can we do if the cervix is unfavorable? We can apply prostaglandin structures to help in the ripening and softening of the cervix, to change it from unfavorable to favorable cervix, to allow the artificial rupture of membrane. Amniotomy is contraindicated in cases of intrauterine fetal death and human immune deficiency virus. It has many hazards. Number one is called the prolapse, but actually it doesn't occur if the specialist has a certain cautiously during rupture of the membrane in the form of performing a small hole and allowing the release of the amniotic fluid gradually, not sudden decrease of the intrauterine pressure, which allow pushing of the cord through the cervical canal. Number two, if we don't use good antiseptic techniques, infection will occur in the form of amnionitis or chorioamnionitis. Number three is the amniotic fluid embolism. Number four, abruption placenta, which actually occur in cases of severe polyhydramnios and if there is sudden decrease of the intrauterine pressure, which must be avoided during amniotomy. After rupture of membrane, certain maneuvers must be done. Check fetal heart rate, because sometimes there is obstruction of the umbilical cord between the uterine wall and the fetus or the fetal head, which decrease the fetal heart rate. Sometimes if there is rupture of the vasa previa, there is sudden decrease of the fetal heart rate. Number two, check rate of infusion in the form of oxytocin. Number three, check uterine contractions and fetal heart rate for 15 minutes. Uterine contraction don't exceed 3 contractions per 10 minutes. Oxytocin infusion can be started if spontaneous uterine contraction don't occur in 6 to 12 hours after rupture of membrane. So after rupture of membrane, we wait for about 6 hours and then will apply oxytocin infusion if the spontaneous uterine contraction doesn't occur. Other beneficial effects, systemic beneficial effects of artificial rupture of membrane: lowering of the blood pressure in cases of preeclampsia, relief of maternal distress in polyhydramnios, control of bleeding in cases of antepartum hemorrhage, relief of tension in abruptio placenta, and the initiation of labor. Artificial rupture of membrane must be delayed in occipito-posterior position. As we said, the occipito-posterior position will take a very long time, and its rotation, internal rotation anteriorly 3/8, depends on the presence of good uterine contraction, capacious pelvis, well-flexed head, and it may take a prolonged time. So the early artificial rupture of membrane may lead to ascending infection. The number 3 of the inducing agents is the prostaglandin. As we know, prostaglandin chemistry is a carboxylic acid synthesized from arachidonic acid. It is usually derived from the amnion, decidua, and the myometrium. Physiologically, it is present in the menstrual fluid, endometrium, decidua, and the amniotic membrane. As regards the mechanism of action, it causes changes in the myometrial cell membrane permeability. Number 2, it sensitizes the myometrium to the action of the oxytocin, which will be added after 6 hours. Prostaglandin has its collagenetic activity after the ground substance of the cervix, which help in cervical ripening, as we mentioned previously. As regards the types of the prostaglandin, most important the prostaglandin E1 and the prostaglandin E2. As regards the prostaglandin E1, it has different route for administration, either vaginal route or oral route. Vaginal route, the dose will be 25 microgram every 4 hours to a maximum 6 doses can be given. As regards the oral route, the dose must be increased because there is absorption and metabolism. So the dose will be 50 microgram every 3 hours to a maximum 6 doses given orally. Other routes of administration is buccal, rectal, and sublingual administration. When we compare the oral route for prostaglandin E1 versus vaginal route, the oral route will less effective, so the dose is higher than the vaginal route, and the vaginal is more effective. The oral less chance of fetal distress than vaginal is more chance for fetal distress. Prostaglandin E1 has advantage and disadvantage as any inducing agent. Advantage: it is cheap, has long half-life, stable at room temperature. Inducing delivery time is short, or induction delivery time is short. Less failure rate. Powerful oxytocic effect irrespective of gestational age, can be applied and effective and safe in gestational age 20, 24, 30, and so on. But it has many disadvantages in the form of vomiting and diarrhea, bronchospasm, so it is contraindicated in cases of bronchial asthma, times uterine hyperstimulation, sometimes tachysystole, fetal distress, rupture uterus. Tachysystole means increased frequency of uterine contraction, more than 3 contractions per 10 minutes. Must be differentiated for hypersystole, which means prolonged duration of uterine contraction more than 2 minutes. As regards the prostaglandin E2, it is can be applied in the form of vaginal gel, 0.5 mg intracervical or vaginal. It can be repeated every 6 hours for 3 to 4 doses if required. Another form is the vaginal tablet. The third form is the vaginal pessary. Vaginal tablet concentration 3 mg can be given in a posterior fornix, followed by 3 mg after 6 to 8 hours to a maximum dose of 6 mg. Lastly, the vaginal pessary, releasing dinoprostol 10 mg over 24 hours. It can be removed when we found there is a good cervical ripening or adequate for completion of termination of pregnancy. When we compare prostaglandin E1 versus prostaglandin E2, prostaglandin E1 is cheap, prostaglandin E2 is costly. Prostaglandin E1 is stable at room temperature, prostaglandin E2 need refrigeration. Prostaglandin E1 is easy to administer. Contraindication of prostaglandin: number 1 is the bronchial asthma, number 2 pulmonary disease. Previous uterine scar is a relative contraindication for usage of prostaglandin structures. Complications of prostaglandin: systemic side effects in the form of nausea, vomiting, diarrhea, fever. Number 2, uterine hyperstimulation, as we said, which is associated with non-reassuring fetal heart rate pattern. Tachysystole differentiated as more than 5 contractions in 10 minutes for at least 20 minutes. Hypersystole means single contraction of at least 2 minutes duration. So we must differentiate between tachysystole and hypersystole. The fourth method for inducing labor is the oxytocin. It is the oxytocin hormone. It is a nanopeptide sensitized in the hypothalamus. And reduced or stored in the posterior pituitary gland. It is a nanopeptide hormone, has half-life 3 to 4 minutes, duration of action 20 minutes. It is used very commonly to achieve induction of labor or mainly in augmentation. The objective to produce uterine contractions that effectively produce cervical dilatation and the descent of the presenting part through the cervical cavity. Mode of action: it acts through the receptors. It stimulates amniotic and decidual prostaglandin production. So the prostaglandin sensitizes the myometrium for the action of oxytocin, and oxytocin stimulates further amniotic fluid and decidual prostaglandin production. As regards the preparation available: ampoules, buccal tablet, and nasal solution. Ampoules has 2 concentration, 5 international unit per milli. Some ampoules 1 milli, some ampoules 2 milli contain 10 international unit. Buccal tablet containing 50 international unit per milli. Nasal solution containing 40 international unit per milli. Route of administration: intravenous infusion, intramuscular, buccal tablet, or nasal spray. But buccal tablet and nasal spray not available in Egypt. Important facts: oxytocin should be used with extreme caution in cases of multiparous women to avoid occurrence of ruptured uterus. Oxytocin or syntocinon should not be used or started before passage of 6 hours after administration of vaginal prostaglandin or after 6 hours or 12 hours after rupture of membrane. If a trial of labor is judged safe, then oxytocin may be used. Oxytocin should be used with caution with previous uterine scar. Oxytocin should always be used in conjunction with partogram once in established labor. As any inducing agents, it has advantage and disadvantage. As regards the advantage: it is cheap and effective, easy to be titrated. Disadvantage: need refrigerator, effectiveness less, with low Bishop score, with intrauterine fetal death or lesser weeks of pregnancy. Hazards of oxytocin: number 1, uterine hyperstimulation and water intoxication. Uterine hyperstimulation occurs if there is 5 contractions in 10 minutes, each lasting for 1 minute, and usually it is associated with abnormal fetal heart rate pattern. And if there is persistent for prolonged time, it may lead to intrauterine fetal death and may lead to rupture uterus, especially in multiple gestation and grandipar. Water intoxication is due to antidiuretic action if used more than 30 to 40 international units. It is usually manifested by hypernatremia, confusion, and coma. Also, the hazards of the oxytocin is fetal distress, uterine rupture, as we said, and hypotension. When to interrupt? When there is interrupt the oxytocin infusion if there is hyperstimulation or fetal distress, or there is signs of water intoxication, and usually sometimes it is usually manifested after 24 hours. But water intoxication is suspected if we use more than 100 international units in interval with less than 24 hours. When we compare oxytocin versus prostaglandin, oxytocin is safe, cheap, and effective. Prostaglandin tablet form is cheap and effective. Oxytocin is unstable at room temperature. Prostaglandin is stable at room temperature. Prostaglandin E1, prostaglandin E1. Oxytocin is easily titrated. Prostaglandin is not titrated. Oxytocin less chance for fetal distress. Prostaglandin more chance for fetal distress. Prostaglandin E1. Oxytocin more effective near full term. Prostaglandin E1 is effective irrespective of the gestational age. Oxytocin less effective with less Bishop score and intrauterine fetal death. Rare methods which is not used nowadays is the hygroscopic dilators, osmotic dilators in the form of laminaria tent or Foley catheter, double balloon device, extra amniotic saline infusion. Balloon catheter is a fluid-filled balloon inserted inside the cervix. The balloon provides mechanical pressure directly on the cervix, which responds by ripening and dilatation. A Foley catheter 26 or specifically designed balloon device can be used. Can be applied either with extra amniotic saline infusion with concomitant oxytocin infusion. Intrauterine catheters. To use the intrauterine catheters work by compressing the cervix mechanically to generate release of prostaglandins in local tissues. There is no direct effect on the uterus. This is the extra amniotic saline infusion application of the uterus, and this is filling the catheter, Foley catheter, and through the catheter we can inject a warm saline, sometimes inject warm saline with prostaglandins. Allow controlled dilatation, ideal for cervix if the cervix firm, posterior, long and closed, severe fetal growth restriction or oligohydramnios. Under complete aseptic technique or precaution, Foley catheter inflated with 30 ml distilled water, 100 ml sodium chloride, extra amniotic space, normal saline, spontaneous passage in 24 hours after dilatation of the cervix, followed by artificial rupture of membrane and pitocin. Lastly, we must know when to perform induction of labor. Each condition has a specific time to perform. Good results for success and gain benefit for the mother and the fetus. In cases of the post-date cases, the induction will occur at 40 weeks plus or minus 7 days. In cases of pregnancy-induced hypertension or hypertensive toxemia or preeclampsia, it varies. If there is no treatment, not on treatment, induction will be done at 40 weeks gestation. If the patient on treatment, more or less 38 weeks, depend on the severity of the condition. In cases of diabetes mellitus or gestational diabetes, if the patient not on insulin, induction occur around 39 weeks. If the patient on insulin, induction will occur at 38 weeks, depend on the severity. Persistent preterm premature rupture of membrane, induction occur more than 34 weeks only in a specialized hospital, especially if there is good pediatrician. Preterm rupture of membrane, induction may be performed immediately or within 24 hours after leakage of the amniotic fluid. Indeterminate antepartum hemorrhage causes, induction will occur by 40 weeks. If there is unknown last menstrual period and the expected date of delivery given by late scan more than 20 weeks, induction will be done at 38 to 40 weeks gestation. Lastly, when we say there is a failed induction of labor, Induction of labor can be said failed if amniotomy is still impossible after maximum number of doses of prostaglandin have been given, or if the cervix remain uneffaced and less than 3 cm dilatation after rupture of the amniotic sac or amniotomy has been performed, and oxytocin has been running for 6 to 8 hours with regular uterine contraction. What is the causes of failed induction? There is different theories. Number one is the placental sulfatase deficiency, lack of essential cytokines, which is essential or playing very important role in the ripening of the cervix. As we said, induction of labor has great benefits, we said in the first slides of the lecture, but it has also many complications which may occur in the form of uterine hyperstimulation, uterine rupture, maternal upset, iatrogenic fetal prematurity, fetal distress, and lastly failed induction. Benefits of induction of labor, maternal and neonatal, regular rhythmic uterine contraction, progress in cervical dilatation, shortness of the duration of labor, good effacement of the cervix, low incidence of cesarean section, less maternal anxiety, fast delivery induction delivery time, fetal hypoxia can be detected early, decreased neonatal mortality rate. Conclusion: during induction of labor, benefits should be weighed against risks. Risks should be assessed. Alternatives should be considered. Necessity of intervention judged. Decision should be taken accordingly. Lastly, unwise use of labor-inducing agents should be avoided. Unwise use of labor-inducing agents should be avoided.